Let me go over burns with you. Most of our discussion will be about thermal burns. But let me have one or two vignettes first to deal with chemical and to deal with electrical burns. So let's begin with a chemical burn. You get a phone call from a frantic mother. Her 7-year-old girl spilled Drano all over her arms and legs. You can hear the girl screaming in pain in the background. All right, the issue with chemical burns is that as long as the chemical agent is still there in contact with the patient, the burn continues to occur. And so the most important issue in the management of chemical burns is massive irrigation. Tons and tons of water in the home setting, eventually sterilizing in a hospital setting, to wash out all the chemical. And this needs to be done as soon as possible. So the advice to this lady over the phone is not, ma'am, rush to the emergency room with your little girl, because during that trip the chemical would still be burning the little girl. The advice is get rid of the clothing the girl has that is soaked with the agent, take her to the shower, have her under the running water for half an hour or an hour, and then bring her to the emergency room. And every time you deal with a question on the exam with chemical burns, please resist the temptation to play chemist. You might be offered an option if a girl was burned with an alkali, like this one was, to bathe the area in an acid. That would be a horrible, wrong thing to do. So we don't treat alkali burns with acid or acid burns with alkali. We treat all of those with massive irrigation. Okay? Now we move to vignette number 8. While trying to hook up illegally to cable TV, an unfortunate man comes in contact with a high-tension electrical power line. He has an entrance burn wound in the upper outer thigh and an exit burn lower on the same side. Now the issue with electrical burns, and the ones we're talking about, are high voltage, big power lines, not the outlet on the wall with 110. The issue is there is always far more damage deep inside than what the physical exam would suggest. You see a little entrance wound, there's a little exit wound, everything underneath is completely destroyed. So electrical burns need very wide debridement and very often amputation of extremities. But in addition to that, you also need to be concerned with myoglobinemia and myoglobinuria, with which you need to check those values, and if they are high, you need lots of fluids, diuretics, osmotic preferably, like mannitol, alkalinization of the urine, and other things too. There are a number of other injuries to be ruled out. When the electrical shock goes through the patient, all the muscles contract at the same time. That can produce posterior dislocation of the shoulder, compression, fractures of vertebral bodies. We need to check for those. Long-term, late development of cataracts and in demyelinization syndrome. And with that, we move then to the thermal burns, the ones that are going to be, in fact, the topic of most of our discussion. Let me read vignette number 9. A man is rescued by firemen from a burning building. On admission, it is noted that he has burns around the mouth and nose, and the inside of his mouth and throat look like the inside of a chimney. One big issue in flame burns that occurred in an enclosed space, a building, a car, an airplane, is smoke inhalation. And you know this is a smoke inhalation. You even have the clue not only of how it happened, flame burns in a closed place, but the fact that the inside of the mouth looks like the inside of a chimney. You realize that this is indeed smoke inhalation. And inhalation injury is one of the things that kills people in a fire. And so the diagnosis is confirmed by doing bronchoscopy. But the management is guided by blood gases, because essentially all we can offer the patient as therapeutic intervention is, if needed, to put him on a respirator. And this is guided by blood gases. So, see how the question is phrased. If the question asks you, how do you make the diagnosis that there was, in fact, inhalation injury, the answer is bronchoscopy. If the question is, are you going to decide on the treatment, the answer is blood gases. We then move to vignette number 10. A patient has suffered third-degree burns to both of his arms when his shirt caught on fire while lighting the backyard barbecue. The burn areas are dry, white, leathery, anesthetic, and here comes the key word, circumferential, all around the arms and forearms. Let's talk about the significance of circumferential burns. You know that underneath a burn there is a lot of edema, a lot of swelling, a lot of fluid that leaves the circulating space and gets into the tissues. Also, a third-degree burn, full thickness, converts the normal pliable skin into a leathery, thick, unyielding scar. When you put those two things together in a circumferential burn like we're describing here, there'll be a lot of fluid trapped in that extremity, but it cannot swell because the skin that normally would have been able to stretch has been converted into that thick, leathery scar that does not yield. And the outcome of that is it will shut off the extremity circulation. So your correct answer on this vignette revolves around checking pulses, capillary feeling, perhaps Doppler signals. And if the vignette says indeed there are no pulses or the capillary feeling is not there or the Doppler signal has disappeared, then we have to do what is called escharotomies. A long cut, this can be done at the bedside. No need for anesthesia, no need for a sterile environment. Cut on one side, cut on the other to enable the scar to distend and thereby restore the flow of blood to the extremity. We now move to vignette number 11. A toddler is brought to the ER with burns on both of his buttocks. The areas are moist, have blisters, and are exquisitely painful to touch. The story is that the kid accidentally pulled a pot of boiling water over himself. Now, this is a classical example of child abuse. We should suspect child abuse anytime a child has scalding burns, but particularly when the story given by the caretaker doesn't match the injuries. If this kid had pulled a pot of boiling water over himself, he would have been burned like this, not on both buttocks. Both buttocks means he was held by arms and legs and dipped into boiling water. So the most important thing in the management of this child is the referral to the proper authorities so the child can be removed from this abusive environment where he is. That's what's going to kill this child, not the burn itself. And with that, we move then to the famous burn formulas for the estimation of fluid needs. Let me read a vignette and then we're going to talk about this. An adult man who weighs X number of kilograms sustains second and third degree burns over whatever. These burns will be depicted in two little drawings, front and back of the patient, shading the areas, and you'll be asked about fluid resuscitation. So let's discuss this and then we'll come to the answers. We know that underneath a burn, a lot of fluid gets trapped out of the circulation into the tissues. Were nothing to be done, the patient would die in hypovolemic shock. Now, most of that fluid will eventually come back into the circulation of the patient about 48 hours later. But in those first 48 hours, we have to keep the patient alive by giving that patient lots of intravenous fluids. Well, it has been deemed advisable to have an idea ahead of time how much fluid would you need for such a resuscitation. And that's why formulas have been developed. I happen to hate these formulas. There isn't one, there are multiple, they only give an estimate, but we may encounter that on the exam. Now here's how it goes. The amount of fluid that is going to be needed depends on the size of the patient and the extent of the burn. So the formulas typically begin with the size of the patient expressed in kilograms of body weight. And that number will be given to you on the question. So the question will say a 72 kilogram man, a 56 kilogram lady, so you get the first number that makes part of that equation. The second number is the percentage of the body that is burned. That number will not be given to you. You get the little drawings that I was referring to, front and back of the patient, shaded areas, and then you have to use the rule of nines to estimate the extent of the burn. The head is 9% of body surface, each arm is 9%, each leg has 2 nines, 9 in the front, 9 in the back, and the trunk has 4 nines, 2 in the front, 2 in the back. And that adds up to 11 nines, that comes up to the 99, for practical purposes, 100% of the body. So then you had the kilograms of body weight, you then multiply that by the percentage of body that is burned, but you do that only up to 50%. If a patient is burned more than 50%, there is no more fluid to be lost. Once they are at 50%, they are losing fluid at the maximum possible rate. So the formula, if the patient is burned 60%, 70%, what you put in the formula is 50 rather than 60 or 70. And then we multiply those two, the product of those two numbers, multiply then by another number, which is the one that is variable from one formula to another. 2 to 4 cc's of a balanced electrolyte solution. The formula most commonly used, a modified parting formula, uses 4 cc's. So the formula that is most commonly used would say put kilograms of body weight times percentage of burn up to 50 times 4. Those are the cc's of a balanced electrolyte solution you need to give the patient in the first 24 hours. And it should be given so that half of the calculated amount goes in the first 8 hours, the other half in the subsequent 16 hours. There is still a little bit more to be added to this first day of therapy, because a patient with extensive burns typically develops paralytic ileus and cannot eat for a couple of days. They also need about 2 liters of D5W, 5% dextrose in water, to account for the fact that they are not eating and drinking. So that's what the patient gets in the first day. And the second day would be half that much. And on the third day, we should need no fluid anymore. And the third day, the patient begins to reabsorb the fluid that was in the burn, and you see a massive diuresis, which is normal and expected and requires no therapy. Okay? Now, having gone into the details of this formula, let me now point out the most important thing about it. These formulas only give you an estimate that enables you to decide how much should you begin to give the patient. But once you are infusing the fluids and monitoring that patient, you then adjust the rate of fluid administration to the patient's response to this fluid infusion. And this is judged primarily by urinary output. We aim to have at least 1 cc per kilogram of body weight per hour, preferably 2. If you're getting a lot more than that, you need to scale back in your fluid administration. If you're getting a lot less than that, you need to give more fluid. So we eventually, in fact, adjust our therapy according to the patient's response. Not to make this particular vignette too long and too complicated, but the fact that the formulas only give an approximation has led some burn therapies to abandon the formulas, in fact, altogether, and to say any patient who's an adult and is extensively burned, they should begin to get fluid at a rate of 1 liter per hour, and then once we are monitoring the urinary output, we can adjust either more or less depending on the response. So when you get the question on the exam that asks about fluid, pay attention how it's worded. If you read a so many kilogram patient is burned over the following areas, you see the little drawings with it, you realize it's an extensive burn. And then it asks, what would be a realistic rate of fluid administration to begin with until such time as the urinary output gives you a better guide? Well, then you got the easy version of this question. And you say, let's begin 1 liter an hour. But unfortunately, you might get the more difficult version of the question. The same data, so many kilograms of body weight, a little diagram showing what was burned and what is not. And then if the question asks, how much altogether do you think is the amount of fluid that will be needed in the first 24 hours? You're going to have to go through the calculations that we already talked about. And this is exemplified in the next couple of vignettes. So let me read vignette 13. An adult who weighs X number of kilograms has third-degree burns over, and there'll be the little drawings, and let's say you calculate that is more than 20%. Fluid administration should be started at a rate of what? This is the easy version. It asks about a reasonable rate to begin with, 1 liter an hour. But vignette number 14 shows you the difficult type of question. An adult man who weighs X kilograms has third-degree burns over, there'll be the little drawings. How much is the estimated amount of fluid that will be needed for resuscitation? You need to go through the calculations to come up with a whole number. Now here are other ways you could be tested on the resuscitation of a burned patient and the fluid. Vignette 15. After suitable calculations have been made, a 70-kilogram adult with extensive third-degree burns is receiving ringer lactate at the calculated rate. In the first 3 hours, his urinary output is 15, 22, and 18 ml. Now you realize that's not enough urinary output. We aim for at least 1 cc per kilogram of body weight per hour, preferably 2. This man weighs 70 kilograms. He should be putting out 70 cc's of urine an hour, preferably 140. And he's only putting out 15, 22, 18. So obviously the answer is you need to increase the rate of fluid administration. Let's read the next vignette, 16. After suitable calculations have been made, a 70-kilogram adult with extensive third-degree burns is receiving ringer lactate at the calculated rate. In the first 3 hours, his urinary output is 325, 240, and 270 ml an hour. That's a lot of urine. We don't need the urinary output to be that enormous. 2 cc's per kilogram of body weight per hour would be sufficient. So up to 140 would be fine. Put out 300, 270, this is a lot more than you need. This individual is being given too much fluid. The answer is scale back. He doesn't need this much. And vignette 17, I hope you'll instantly recognize what this illustrates. During the first 48 hours after a major burn, a 70-kilogram patient received vigorous fluid resuscitation and maintained a urinary output between 45 and 110 ml an hour. On the third post-burn day, after IV fluids have been discontinued, his urinary output reaches 270 to 350 ml an hour. You say, what's wrong? Why is he putting out so much urine? Nothing wrong. This is what you expected. This is what is going to happen because now he is retrieving his own fluid that he had misplaced temporarily under the burn area. Now let's do a little review of this same issue in children. This is vignette 18 now. An 8-month-old baby who weighs X number of kilograms is burned over, and there'll be the little drawing. Second-degree burns will look the same as in the adult. Third-degree burns look deep bright red. Here is how burns are different in children. When you calculate the needs, when you use the formulas, The rule of nines is different for children than it is for adults. In adults, the head is 1 9. Both legs add up to 4 nines. In children, the head has 2 nines. They're big heads. And both legs add up to 3 rather than 4 nines. In addition to that change, also in the evaluation of the fluid needs for the babies, we assign an even higher number in the formula. Kilograms of body weight times percentage, and then we multiply that by anywhere between 4 and 6, rather than, as we said for the adults, a number between 2 and 4, depending on the formula that you use. I might add, although it's obvious, the arbitrary addition of 2 liters a day to account for the fact that the patient is not eating and drinking obviously cannot be applied to little babies. They will need an additional amount commensurate with their size. All right, we're getting close to the end of the burn area. We still have 2 vignettes. Vignette 19, a patient with 2nd and 3rd degree burns over 65% of his body surface is undergoing proper fluid resuscitation. The question asks about management for the burn areas and other supportive care. So here is a summary, and this is indeed a summary. All burns need tetanus prophylaxis. Then we typically begin with suitable cleaning of the burn areas, often in an operating room, and then the use of topical agents to keep the burn area from being a portal of entry of bacteria. The standard agent we use is silver sulfadiazine. If deep penetration is desired, like thick eschar or cartilage, mafenite acetate is a choice. But we don't use it everywhere. It hurts and it can produce acidosis. Burns near the eyes, we use triple antibiotic ointment because the silver sulfadiazine is very irritating to the eyes. Pain medication has to be given IV, and those first 2 days when you have a fluid shift, you cannot rely on intramuscular or sub-Q. After about 2 or 3 weeks, grafts will be done to the areas that did not regenerate, and after an initial day or 2 of nasogastric suction, intensive nutritional support is needed, preferably via the gut rather than TPN. And finally, rehabilitation has to be started from day 1. And now we come to the last of the vignettes on burns. A 42-year-old woman drops her hot iron on her lap while doing the laundry. She comes in with the shape of the iron clearly delineated on her upper thigh. The area is dry, white, leathery, and anesthetic. The standard burn care for a patient with extensive burns is very expensive and very hazardous and very painful for the patient, because the standard care is 3 weeks. Intensive care, nutritional support, fighting the possibility of infection until the areas that were burned are ready to be grafted. But if we have a patient with a very small area of clearly full thickness, 3rd degree burn, it's a lot easier, quicker, cheaper, simpler to take that patient to the operating room, throw away that burned skin and put a skin graft right away. We call this early excision and grafting. Let me show you an example of what you might encounter in an exam to make it obvious and clear that this is the way to do it. 42-year-old woman drops her hot iron in her lap while doing the laundry. She comes in with the shape of the iron clearly delineated on the upper thigh. The area is white, dry, leather, anesthetic. You realize we had read this already before, but now that you have a background, this is a teeny bitty area. It wouldn't make any sense to subject this lady to 3 weeks in the ICU with a lot of pain and a lot of problems. You take this lady to the operating room, you cut and throw away that dead skin, you put a skin graft, and you're done with it. Early excision and grafting. And that brings us to the end of burns.